Hello, good evening, welcome and assalamu alaikum. Welcome back, everybody. Today's lecture will be on infectious diseases. I hope you all are ready. By the week, you have prepared well and you are keeping yourself and your family safe in these tough times. So, today we have one special thing for you, and that is 100% guaranteed track medicine question giveaway. So, for those of you who are going to stick with us till the end, we will definitely be giving you two questions that are definitely going to come up on your exams. These are not your real exam questions, of course, disclaimer, but definitely you can expect them in your MRCP Part 1 exam. So let's begin with the first question of the day. Okay, so as usual, our star students have started answering, and seems like all of you are thinking in the right direction. Okay, so most of you have answered correctly. This is Aspergillus fumigatus, and you have guessed it correct. This is how it looks. Please note that there are no images that are gonna come up on your MRCP Part 1 examination. All the images over here that will be displayed today are only for your educational purposes. Okay? So let's talk something about Aspergillus fumigatus. This is usually seen in the places where there is building work going on, that is construction site. So construction site is the one. Why construction site? Because construction sites, they throw up a lot of dust and spores. Okay, so the Aspergillus spores are the ones that cause the infection through the building construction works. Also, this is seen in decaying organic matter. Where do you find decaying organic matter? In the soil, right? So it's seen in the soil. Then what happens in a normal person? Normal person inhales around 200 to 2000 spores every day, but nothing happens to the normal person. Why? Because our immunity kills all of these spores. But then it causes aspergillosis in cases of people who are immunocompromised. All right. I am actually very happy to see that all of you have answered it correctly. Okay. So if the person is immunocompromised and you encounter aspergillosis, so what will be the treatment modality over here? First will be considering what kind of immunosuppression is being given. So you will have to modulate the immunosuppression, reduce it a bit. So you can reduce the immunosuppression, that is the first line of treatment, depending on the situation. But you can definitely give voriconazole. Okay. All right, so this is how you treat aspergillosis. Let's move on to the next one. Okay, so again, Karthik, Priya, Dr. Aisha, Tinu, all of you are right. Satyam, Renu, all of you are absolutely correct. The answer over here is D, anesthesia puffer. And I hope I marked the answer in this one. So this is A. Yeah. So the answer to your question is D, malassezia puffer. This is how your malassezia looks on a slide. Now, some of you may call it as Pitrisporum orbiculare. That is basically the yeast form of malassezia. And these are the hyperpigmented macules that the question was talking about. You can see that these are distinctively different from the skin. Okay. And the wonderful thing how to differentiate is that these will not get tanned. Okay. Usually, when a person is tanned, these hyperpigmented macules will not get tanned. So that's how you're going to differentiate them from skin discoloration. Okay, so these are some more examples. Okay, so here's something called as, this is the one, if you look here closely, right? So this is the one called as Trichophyton rubrum, the one which was given, and this is what you know as athlete's foot. Okay. Athlete's foot occurs when a person walks barefoot, usually in a moist environment or something. So now, as the question mentioned that the patient was given with topical steroids and it increased the rash. Okay, so when you give topical steroids and the rash goes on increasing, that's very characteristic of a fungal infection. Okay, so this person in the question, you should investigate this person further for immunocompromised status. Okay, so the next question in this line would be, what is the next line of investigation you would want to do? So you would investigate the patient for immunocompromised status as to why in the first place this thing happened. Okay. Okay, let's move on to the next one. Okay, so we are extremely sorry for that interruption. I think you all have actually started answering it correctly. So the right answer for this one is Leptospira interrogans, which causes leptospirosis. Now, if you read here in the question, there is a very important word written called no rash. Okay, so this no rash is basically eliminating some of the options. Okay, now canoeing is a recreational water sport, and let's see. So this is your leptospira over here, and this is usually present in the people who handle sewage water. I know it's an unsightly look, but then yes, this is the reality. And rat's urine is the one which transmits this infection to some people. Also, it happens in water sports like canoeing or other things, river rafting and other things. So let's go on and find out something more. So as we read in the question, it's present in people who go for recreational water sports. Please note that this is water sports, recreational water sport. If the question stem mentions something about freshwater lakes and other stored water kind of a scenario or situation, most probably person coming back from Africa, then that has a different DD, and we'll come up to that like eventually. So it's also seen in sewage workers and people who are involved in fish farming. Fish farming also involves a lot of water logging, so that's how it happens. Now, the clinical features are very vague. Initially, they could give you a headache sort of a picture, not to the doctor but to the patient. Patient might also present with fever, myalgia. Okay, so just generalized vague sort of features. But then, eventually, within 4 to 7 days, the patient will develop neck stiffness. Now, here's where the problem starts. Okay. Then next you have vasculitis and meningitis developing. So you see the disease goes on increasing in its severity eventually. And finally, something called as Weil's disease develops. Now, what is Weil's disease? When you have jaundice with renal impairment, this is known as Weil's disease. What will you see in renal impairment is proteinuria. Okay. This is specifically known as Weil's disease. Now, how will you diagnose the condition? The diagnosis is via blood cultures. You can also have urine culture, and you can perform a PCR serology. Okay. Treatment is via doxycycline. Usually the treatment is 100 mg doxycycline BD for 7 to 14 days, and that's how it goes on. Uh, Something to note over here is that whenever you encounter any disease in infectious diseases questions, which does not give you a very vague, like it does not give you a very specific set of answers like in the pointers, okay? So it might not be necessary that the question is going to ask you about the diagnosis, okay? Because sometimes in the real life scenario, as you will see and as you all might be actually noticing, it's very difficult to pinpoint the diagnosis, okay? So sometimes RCP will actually just ask you about the treatment protocol, okay? So in infectious diseases questions, when you are totally confused, yes, Karthik Priya, you are right. Cystosoma is the one that I was talking about earlier. Yes, you're right. So in such questions, when you're confused about the answer, go with doxycycline, okay? Just a small thing. Okay, so the next one. Dr. Aisha is quick to answer on this one. Mehmet says C. Okay, so the correct answer to this one is C, that is Streptococcus pyogenes. This is how your erysipelas looks like. Okay, so talking about strep pyogenes, not only causes erysipelas, but it also causes impetigo, and then you have cellulitis. Okay, yes, you are right. Talking about groups, this is a group A. You are right. What's your name again? Pavan. Yes, Pavan, you are right. This is a group A beta hemolytic strep pyogenes. Okay, so these are the things that it can cause. How will you treat it? Treatment is via penicillin. This is also the one that causes post-streptococcal glomerulonephritis, PSGN. Okay, so you will treat it with penicillin. Okay, so while we are talking about this, I would also like to mention that in young patients' cases, when you come across acute epiglottitis, okay, this is usually caused by H influenza B, that is Haemophilus influenza B. Okay, and the question will mention something called as stridor. Patient will be very young, let's say 2 to 6 years old. Okay, very young child having stridor. It will be usually acute epiglottitis, H influenza B. Okay, let's see the next one. So we are talking about vaccines, very hot topic right now in the world. Okay, so Karthik, Renu, Tinu, Satyam, Pavan, and Hiren, all of you are right. And Rabia, if you are talking about bee influenza, okay, so yellow fever is the right answer. If you're talking about bee influenza, yes, there can be other types of vaccine, but in this particular question, here is the one which will remove your confusion. Okay, sometimes the answer can be ambiguous, so you have to go with the most common one. Okay, most likely example. Why yellow fever? Yellow fever, we are talking about yellow fever is because it's usually given to travelers. When you travel across borders, yellow fever vaccination is mandatory. Okay, and then in that case, it becomes a difficulty when you don't know which one is a live attenuated vaccine. Talking just a little about vaccine, these are the three main approaches to making a vaccine. So you can just have the genetic material, the virus, or you can take the parts that trigger the immune system. Okay, so these are your immunogenic particles, or you can use the whole bacteria. Okay, the whole virus or the bacteria. Now in this case, when you're using the whole microbe approach, you can make basically two types: inactivated vaccine, wherein you take the virus and you kill it basically, and the structure remains the same, or you can have the vaccine being live, but there will be a little bit of reduction in the virulence. Okay, not a little, quite a lot amount of reduction in the virulence of the virus. So that's called a live attenuated vaccine. And then you can genetically engineer the vaccine also. I will not talk in detail about vaccines because you all are very much quite aware with the vaccines and the ongoing situations. So let's talk about the questions again. So this is the table that you need to remember, and you can definitely expect one question from here. Talking about live vaccines, it is basically contraindicated in pregnancy. Okay, so you will not give this to a pregnant lady. Also, you will not give this to a person who is on immunosuppressants or is undergoing any immunocompromised state. Thus, the relevance of this table. I have intentionally left few spaces over here so you can fill up more as much as you like. You can make this table your own. Okay, the next one, please. See, when all of you start answering very correctly, very quickly, that is what gives me the biggest happiness that can, that can be given to anyone. Okay, so all of you are correct. D is the right answer, and sulfonamides basically act by inhibiting GABA into folic acid conversion. Now, what you have to actually understand here is this question can also become a part of the pharmacotherapeutics chapter. Okay, you can also see it in infectious diseases chapter. So, what does it mean? It basically means that all of these are linked, right? So, medicine as a whole is linked. The organs are not separate from each other, they all work together like a harmonious team, right? So when you are studying something and something else comes up with that, like here for example sulfonamides, so when you look up about sulfonamides, be sure to go and see where and all it acts, how it acts. Okay, so have the complete picture in your head. That will help you go a very long way, because once you link the things, link the chapters in your head, how each of them are linked to each other, like Karthik Priya mentioned earlier about schistosomiasis when I was talking about freshwater lakes. So such keywords should trigger those things, right? So schistosomiasis, freshwater lake. So how does it come? It comes only when the things are linked in your head. Okay, your brain really loves links. So try to form links on the basis of something that you have already studied. Try and add on information onto that one. Okay. So let's move on to the next one and let's see the right answer. So we'll talk a little here about how the antibiotics work. Okay, this one is basically a very good demonstration of all the antibiotics and all the mechanisms in one place. You can see these are the folate inhibitors, sulfonamides and trimethoprim. You can also see that the most famous ones, penicillins, are the one that inhibit cell wall synthesis, right? So antibiotics, mechanism of action. All right, so you can go through this and you can also expect one question from this one. Please note that sometimes they can actually give you like 30s subunit and 50s subunit uh, protein synthesis inhibitors, so you need to be very sure about this. And DNA gyrase quinolones, they are very notorious, so you can also remember this. Now, like I said about remembering things and links, suppose when I think about quinolones and then what else they can cause, what are their side effects, you can basically link it to this picture over here, okay, when you're making your own notes. Okay, enough of talking. So now let's move on to the next question. Okay, so all of you have answered, and the right answer is A, azithromycin. So when we are talking about chlamydia, okay, so this has the habit of not working sometimes. So when we are talking about chlamydia, this is definitely the most prevalent STD in the UK right now. So you have to be very thorough with this one. It's an obligate intracellular parasite. So if you have a cell, they have this habit of living inside the cells. Okay, so you can find them here. When you stain them, they will stain like this. Okay, so that's what an obligate intracellular bacterium means. So this is the most common infection STD in UK. Why I am saying this again and again is because this makes it an important question. So what are the clinical features? The clinical features are asymptomatic. So 80% of the patients, they will not have any symptoms. So then how will you diagnose it? Uh, yes, Satyam, you're right. Doxy can also be used. So how will you diagnose this? In case of diagnosis, no, it's not just the bacteria and viruses that are opportunistic sometimes. Doctors are also opportunistic. And the guidelines say that you have to be opportunistic in terms of diagnosing chlamydia. Okay. So whenever there is a patient contact with you who is aged of 15 to 24-year-old, both males and females, you can test for it. Okay. Now, how will you test for it? Because it's given in the National Chlamydia Screening Program, okay, NCSP of the UK. So that's how you have to test for it. How will you test is via NAT, nucleic acid amplification test. Okay. Now the samples for NAT will be what? They can be the urine sample, they can be the vulvovaginal samples swab, or they can be higher cervical swabs. Okay. Yes, Kartik Priya, NAT is correct. So but in case if if they mention something like symptoms, so in females it will usually be cervicitis. So there will be a discharge, there can be bleeding also. These are the symptoms of cervicitis. Then there will be dysuria, and in males it's usually vague, but then it can be urethritis and dysuria. Okay. So what are the complications? Why do we want to treat chlamydia? Because it causes PID, pelvic inflammatory disease, that is endometritis for an example. Okay, you can also get increase in the ectopic pregnancy frequency. Both of these will actually lead to subfertility or infertility. And you can also have perihepatitis. That's called as Fitzhugh-Curtis syndrome. Okay, so very important information. All of you have the OHCM book with you, that is the Oxford Handbook of Clinical Medicine, whatever be the edition, 9th, 10th, whichever you have. If you have some of your seniors book or anything, 8th edition also will do. There's a chapter which has eponyms, right? Eponymous syndromes which have names. Now RCP is very fond of it, so I would strongly suggest you that try going through it. Don't go through it all at once. Make it a point that before you, let's say when you go to sleep, before that just read two of the eponymous syndromes. Totally it would be somewhere around 3 to 4 pages, but it's very high yield. Okay, you can definitely expect one question from that. So coming back, so apart from this, you how will you treat it? like Satyam said, you can give azithromycin or azithromycin 1 gram single dose, that is oral, or you can give doxycycline 100 milligram BD into 7 days at least. You also have to find out about the contact tracing, that what were the partners. In case of females, you can trace up to 6 months. In case of males, at least up to 1 month before. Okay, and the ideology is treat and then test. So first you will treat the person and then you will test the contacts if they are positive or not. Okay. Now, like Satyam said, one of you said, yeah, Satyam said that doxycycline can also be used. Usually it will not happen like that, but in case if both of the options are given, like if you have azithromycin also and you have doxycycline also, then azithromycin is the preferred answer. Why? Because if you look over here, you have to ask the patient to take a tablet twice daily for 7 days. Now that might sound very easy for a doctor to write it down on a paper, but actually following it for 7 days is not something which is very easy for a patient. Okay. So it's not going to go down very well with the patient, called as patient compliance. That's why a single dose azithromycin is a better answer. Okay, but yes, you're absolutely right. Doxycycline is also correct. Let's move on to the next one. Okay, so Tinu is quite quick to answer. Okay, so Renu also says E. Dr. Asha says E. Yeah, so yes, all of you are right. E is the correct answer. Yes, Karthik, you are absolutely right. Cold agglutinin test can also be used for it, but this option was given over here to make you understand of such options. When they come up in the exam, you have to go with the most used one, okay, the most common one which we use. Okay, so urinary antigen test is quite easy to perform and it's very easily available, so you can actually do it. It's like a card test, so you can do that. So we are talking of Legionella. So diagnostic is urinary antigen test. What happens usually over here is you get hepatitis also, and you get renal failure also, and apart from obviously the respiratory symptoms, and then you have hyponatremia. This leads on to confusion sort of a picture for the patient, also for the patient, also for the doctor. So if you want to know more about Legionella, we have covered that in our video on respiratory medicine, pneumonias. So you can go and watch that and you can get to know in depth about Legionella. Okay, so I will not be covering much over here. Just a smaller thing. Treatment is with clarithromycin. Okay, first line. All right. The next one. And as far as Karthik is concerned, you will use cold agglutinin mostly in cases of mycoplasma. Okay. Okay, so all of you are already answering, which is quite impressive. Okay, so there's a small error, should be wound. Sorry about that. Okay, so all of you have answered augmentin, that is comoxiclav. So like I said, this question is the one that is definitely going to appear on your MRCP Part 1 examination. Okay, so question on dog bite, you can write it down in your notebooks that it is definitely going to appear. Okay, it's very high yield and it's very small also. So basically what happens in a dog bite is you get an infection. Which is that infection? Most commonly it's Pasteurella. Okay, so either they will ask you what is the treatment or they will ask you what is the causative organism. So Pasteurella is the causative organism. So what is the treatment? The most common treatment is coamoxiclav, amoxicillin clavulanic acid, that is augmentin. Now if the patient has any contraindication to amoxicillin, then you will give doxycycline plus metronidazole. Okay, so this is how you treat it. While on the topic of dog bites, let's also see what causes cat scratch disease. So tell me what causes cat scratch disease. But as far as all of you are concerned, this is a definite question. Okay, so I should actually mark it down in red. Any answers? Start with B. Yes, absolutely right. It's Bartonella Hensley. Okay, so that makes me really assured that you all are really revising it very properly. Okay, so let's get to the next one. Okay, so Karthik Priya, Dr. Aisha says D. Anyone else wants to take a chance? Yes, all of you are absolutely right. It is the Trypanosoma cruzi. Okay, so talking about trypanosomiasis, another very important topic for your part 1 examination. Basically, there are two types of diseases that are there in this. The American form is Trypanosoma cruzi that causes the Chagas disease. This is Chagas disease. Okay, so this happens in the land of dreams. And on the other aspect, if you go to the African continent, you can have two types of trypanosoma, east and west. So in the eastern side you will get Trypanosoma gambians, and on the western side you will get Trypanosoma rhodesians. These actually cause something called as sleeping sickness. Okay, so all of you are very familiar with that. Now coming back to Chagas disease, usually in the South American continent. Okay, so the acute form of Chagas disease is very non-specific. You won't find any very specific words for this one. So it lasts for about 1 to 3 weeks. But then you have something called as a chagoma, that's a nodule. Okay, and then you also have something called as Romaner's sign. Romaner's sign is swelling of your eyelids or periorbital swelling. Okay, so these can be there in the acute one, and the chronic infection is the one that is the most dangerous one. So in the chronic infection you can have many complications. The infection lies latent, and after months of infection you can get, let's say in CVS you get myocarditis, then you get um, conduction defects, that is, let's say right bundle branch block, or arrhythmias, or you can also have signs of heart failure. Then in your GIT is the one that is mostly affected. You have megacolon, that is the most characteristic sign of Chagas disease. You can also have megaesophagus. Yes. So how will you treat this very dangerous condition? You will treat it with benzimidazole or nifurtimox. I hope you all are. Kartik Priya says Brusa is in Africa. Yes, you are right. Uh, I hope all of you are following along. Okay. So for those of you who have not subscribed, please subscribe to our channel. Moving on to the next question. Okay, you guys are absolutely nailing all the questions back to back. So I think all of you are very well versed with infectious diseases, and that is my target, that you should know all of these diseases very well. This is what a black SR looks like. While we are on the topic of anthrax, this is a very nice bioterrorism agent. Okay, so this is caused by Bacillus anthracis. Easy name to remember. Then it's a gram-positive bacilli, like you read. Basically, anthrax has three forms of diseases. The first one is cutaneous. Okay, what is the cutaneous form of anthrax called? Please tell me, guys. So this is the most common one, which is present in 95% of the infections. So this has a very good output, and you can treat it very easily with penicillin. If allergic or something, then you can use ciprofloxacin. Then the next one, which is the most dangerous form, it is the pulmonary form of anthrax, which is exactly the bioterrorism form. So it causes pulmonary hemorrhage. Yes, Karthik Priya, you are right. Cutaneous form is called as malignant pustule, which is neither malignant nor there is any pustule. Okay, so you also get pulmonary hemorrhages over here, and you get pulmonary edema, and you can also get cardiogenic shock because of the pulmonary edema. Okay, so the third one, which is the rarest, that is GI. Okay, so the GI causes are rarest, and basically this happens via spores, or I'll write it that side so you can remember it easily. Okay, so that's all about anthrax, and let's move on to the next one. So this is quite an interesting question, quite a huge one also. You can expect long questions in your exam. That's why the need of the keywords. So you need to have those keywords for all of your questions, so that you can be very sure about the answer, because the options are designed to confuse you, and since you don't have four but you have five options over here, more likely to get confused, but less likely to get confused if you know the keywords. Okay, Karthik, Priya and Dr. Aisha are usually answering very quick and very correctly. Anybody else? No. Okay, so the right answer for this one is Brucella melitensis. Yes, Renu and Satyam, you are right as well. Okay, so here we have some lovely pictures. So Brucella melitensis is caused via sheep and goat, and you have Brucella sui, which is caused by handling pigs, and you also have Brucella borders, that is caused by handling cattle. So that's how you can remember this. It's a gram-negative Coccobacilli on the Castaneda medium. Okay. Okay, so we are having some issues again. Right. So Brucella melitensis, also known as Malta fever. Okay, so now you understand this is one of the big reasons why you shouldn't have unpasteurized milk, and so you can advise your patients as well. It happens usually via consumption of unpasteurized milk from sheep, and you can also have occupational exposure. So the symptoms will be very vague as usual, fever, myalgia, but you have to pick up from the occupational exposure clue in the question. There can also be weight loss. Okay, you can also have increased lymph nodes, that is lymphadenopathy, and you can also have hepatosplenomegaly. So finally, the treatment, like I said, whenever any animal is involved in the question, you can easily go with oral doxycycline. The dosage remains the same. Okay, so in the options you also had listeria, which is basically a gram positive bacteria, and Corynebacterium species are also gram positive. Okay, so if you know, somehow you can actually rule out the other options also. So there's no harm in ruling out the options which you're not very sure about. Moving on to the next question. Okay, Renu, you are quick to answer. Okay. Diagnosis is quite clear, but how will you treat, right? What is the most appropriate next step in the management? Okay, so all of you want to start the IV antibiotics immediately, but RCP wants to differ with you, and they want to go with having multiple set of blood cultures and extracting the ICD, because what happens here is, in cases of device related infections, okay, like in this one, like you had an implantable cardiac defibrillator, you, like it was given in the question stem that the when the ICD lead had basically the vegetation, so you have to take out the source of the infection. Okay, and since the treatment is going to be very long, like let's say approximately 6 weeks or so, And you also have to take multiple set of blood cultures, like around 6 set of blood cultures are usually required for going ahead with bacterial endocarditis. So before starting such a long treatment, it is very prudent to identify the organism. Okay, so you can take the ICD lead and you can culture that for identifying the organism, and you can also have blood cultures. Okay, so then you can start the treatment with IV antibiotics initially, like whatever is the cause. Okay, so let's talk about bacterial endocarditis. Okay, here you have a device related infection. We will talk more about it in cardiology. You have to have 6 cultures, 6 set of blood cultures at least. Then you have to give treatment for 6 weeks. This treatment will be guided on the result of culture and sensitivity. Okay, so that's how. Usually the causative organism will be Staph aureus. Also it can be Pseudomonas aeruginosa. So you can have cons, that is coagulase negative staph. Okay, so that's how you treat this. So next one. So we are 2 more questions away from a short break. So we'll go through this quickly. So there's the clue in the question. It's kind of ambiguous right now, but then there are certain clues. Okay, so Karthik, Dr. Aisha, and Tinu are very quick to answer. Okay, so the right answer for this one is bacterial vaginosis, and I will tell you why. Okay, so for Malik, Hiren, Renu, you can see from here whenever you have, this is very strictly related to MRCP part 1 examination. So in real life you are actually right, it's very difficult to diagnose just based on the history, but as far as, yes, for one, it's, you're right, as far as the RCP is concerned, this is how they will point you towards the answer. So you need to remember this very clearly. When you have this gray white discharge with fishy odor, okay, so this word means bacterial vaginosis. Also you can have clue cells on microscopy. Okay, and you basically have something called as Amsel criteria, which helps you diagnose bacterial vaginosis. So you have pH more than 4.5. Please note we are talking about the vaginal pH over here. Okay, then you have A, that is when you add potassium chloride, then you get this offensive fishy odor. Okay, so how you can remember this is via packed. Okay, so C means clue cells on microscopy, and T means thin, gray or whitish discharge. Gray discharge will usually be mentioned in your question. Treatment is very simple: oral or vaginal metronidazole, and clindamycin as well. Be very thorough with this table. Okay. Also, in cases of chlamydia and gonorrhea, if you look over here, the symptoms that are mentioned are usually very similar. Okay, but how you will diagnose chlamydia is there will be given something like deep pain in the history, like when you palpate the patient, the abdomen of the patient, when you palpate, there's a deep pain pointing towards PID. Okay, so that's how you can diagnose chlamydia. Okay, so we'll solve this one and we'll take a short break. So the question is basically diagnosing what Bob has. Okay, so Karthik writes dengue in caps. Okay, so I am happy to see that you guys don't even need the options to know what is the right answer. Okay, so all of you are absolutely right. Dengue fever is the right answer. Okay, why? If you look over here at the platelets, they are slightly reduced right now, but they can actually go down very much. And one more thing over here, 3 thick and thin films are negative for malaria. Okay, so this is basically the diagnostic criteria to rule out malaria, unless the question specifically mentions that 3 thick and thin both the films are negative for malaria, don't rule out malaria. Okay, so if the question does not mention anything about staining, like films they have been done or they have not been done, don't be very quick to rule out malaria. Okay, but in this case it is definitely ruled out. Okay, so let's talk a little about dengue fever. Okay, so you can expect this in travelers caused by Aedes aegypti mosquitoes, and incubation period is usually about 7 days. So initially the patient will mention non-specific signs like headache, but you know what, headache is actually clinically also the most specific sign for dengue fever that we have encountered. But as far as the questions are concerned, there will be severe retroorbital headache. Okay, and you can also have frontal headache. Then you have a generalized maculopapular rash. You can have palatal vesicles, and okay, and scleral injection. Biggest thing is fever. I have missed fever. Okay, so the complicated versions of dengue fever are dengue hemorrhagic fever. This gives you a picture like DIC, sort of a picture, and it also gives you a picture of dengue shock syndrome, DSS. Okay, and as you have read in the question, breakbone fever, that's why it's called, because it gives that pain. Okay, so whenever you're confused between chikungunya and dengue fever, please go have a look at the platelets and you will get your answer. Okay, now a small request for all of you, apart from the live chat, guys, please do go and comment in the comment box of the video, because I'll be taking a short break for 10 minutes right now. Please go ahead and comment in the comment box, apart from the live chat, whether you like this video or whatever is your opinion. Please be honest with it so that we can learn and improve. So here's the time for a quick short break, and see you guys in 10 minutes. Welcome back, guys. Thank you for waiting. I hope all of you are refreshed again for the next round, and let's start with the next question. Okay, some of us are joining us back. There you go. I want all of you to answer this one so that I can check whether all of you are back again. Malik, you are absolutely right. And Karthik, you are right as well. It is intravenous artesunate. The giveaway to this question is the blood film, which says 6% parasitemia with Plasmodium falciparum. So this is basically, okay, yeah, this is basically severe malaria. Okay. Let's talk in depth and we will cover the points that Karthik is raising. So basically we will divide it into two, falciparum and non-falciparum malaria. Okay, so in the falciparum you have very severe features like prostration and very high fever, like more than 39 degrees. Then you have decreased consciousness. You can also have convulsions. And you can have circulatory collapse and shock. These are the general features, but what you basically need to define is whether this is a severe malaria or not. Okay, so most of these features point towards severe malaria. Okay, now you can also have hemoglobinuria. So in severe malaria, you have more than 2% parasitemia. So when you see severe malaria, please go with IV options, usually IV artesunate. And in case of the patient returning from an endemic area like Africa or East Asia, chloroquine resistance is very much common. Okay, so try and avoid chloroquine or quinine in cases where you think resistance will be common. Okay, so there are some other complications that you should know with malaria. I'm just talking about pathology a bit, then we will dive deep into the treatment part. You can have cerebral malaria, that is the most feared form. Then you can also have black water fever, that is due to intravascular hemolysis. Okay, and you can have DIC, you can have seizures, coma, hypertonia, upgoing planters, all of these pointing towards cerebral malaria. In severe malaria, the treatment will be very simple: IV artesunate. Okay, and in uncomplicated, falciparum malaria, you can have treatment giving combination therapy. Okay, so the combination therapy will be artemether plus lumefantrine. It's a bit confusing, so I would want you guys to understand it very clearly. Right now we're talking about falciparum malaria, okay, and we're not talking about the other malarias. So you can also give artesunate plus mefloquine. Now, mefloquine is notorious for causing psychosis and depression, and it can actually cause hallucinations and a very severe acute psychosis attacks. So, if the history mentions anything that the patient is on anti-epileptics, the seizure threshold is low, or it's the patient is depressed, or she has had acute psychosis attacks before, then you should try and avoid mefloquine as an answer. Okay. Please be aware of this. Okay, so you will also be asked about the therapy in pregnancy. So just remember that artemether and atovaquone are contraindicated. Okay, so coming to non-falciparum malaria, and like I said, you need to have three thick and thin films both to rule out malaria. Okay, don't be in a hurry, see whether it's given or not. If the sentence saying the three thick and thin films have been negative, this sentence is not present, then don't be in a hurry to rule out malaria. Okay, so in non-falciparum malaria, you can have Plasmodium vivax and Plasmodium ovale. You can also have Plasmodium malariae. We will talk about these two because they have a hypnozoite stage. This stage is present in the liver. Okay, so they go and sit in the liver of the patient, and that's why you need to add primaquine. You have to add primaquine to the therapy because the primaquine will destroy the hypnozoites in the liver. Okay, otherwise you will have relapses. So this is how you treat these two. And there are certain other things that you should know, some certain side effects, like I mentioned about mefloquine, the side effect is psychosis. Then in cases of chloroquine or quinine, the major side effect is hypoglycemia. Okay, so you need to be very much aware of this. And they can ask you that the patient has been started on quinine, so what is the next investigation you want to perform. In the course of action, you can see whether measuring the blood glucose serum glucose levels is there. You can go with that. Then I don't think there's anything else in this to be discussed. Chloroquine can be taken usually as a treatment option, but do remember that chloroquine has very high resistance, so this should not be the first of your options. Okay, and talking about prophylaxis, you have mefloquine, sorry, not mefloquine. Um, Mefloquine will usually be given in the prophylactic picture. So the question will usually say that the patient was taking mefloquine prophylaxis and then she went on to develop some psychotic symptoms. So be aware of that. You have Malarone. So Malarone is the name, which is basically your atovaquone plus proguanil. Okay, so this is what Malarone is. You have to start this 1 to 2 days before travel, and you have to, the most important point is you have to continue the treatment 7 days after return. So you will see in the question stem reading that the patient started the prophylaxis, and after the patient returned, but she stopped the treatment, the prophylactic treatment, eventually in her trip, while her trip, or she did not continue it for 7 days. So you can think of malaria in that case. Okay. Okay. So in cases of pregnancy and non-falciparum malaria, you can have treatment. You need to understand how will you treat a pregnant patient, because this is important. Please remember that chloroquine is not contraindicated in pregnancy as per RCP guidelines right now. This can be taken, but it also has high resistance. So remember that. So you have to avoid both Malarone and doxycycline. So doxycycline is contraindicated, okay, and primaquine is also contraindicated. It's quite confusing, but I have tried to mention all the important points that you should remember. So in cases where you need to give the combination therapy with, let's say, quinine and doxycycline, in cases of pregnancy, so what is the treatment that you will replace with doxycycline? To find out the answer, you have to see the next question. Okay, anyone else wants to take a chance? Don't worry, in the real exam the questions will be quite straightforward. Mostly it will be giving you a very high parasitemia levels. So it will usually be a Plasmodium falciparum question. So don't get worried a lot. Start IV artesunate treatment in that. And all of you are absolutely correct. Tinu, Pavan, Karthik, Renu, Dr. Aisha, and Malik has not answered yet. Okay, so quinine plus clindamycin, because in this case doxycycline was contraindicated, so you have replaced doxycycline with clindamycin, like I said earlier. Okay, so that's how you go about treating malaria. Now let's see this one. So earlier we were talking about diagnosing these conditions. Now let's see how to treat these conditions. Okay, Renu and all of you are very quick to answer correctly. I get surprised sometimes how all of you are answering all the questions correct while you're preparing, which is amazing. So this is how you go about treating Noria. Okay, so there's a big and here. You have to give both. You have to give ceftriaxone 250 mg IM as a single dose, as well as azithromycin 1 gram oral as a single dose. Yes, Malik, Pavan, Renu, all of you are correct. So this is how you go about treating gonorrhea. So the next one is here. So traveler's diarrhea is actually an important question, and you have to be very familiar with what are the causes and how each of them differ. I think we discussed this previously in the gastroenterology class. So I want all of you to answer it correctly. Okay, so all of you are answering it simultaneously and correctly. Again, Shigella is the right answer, because when you see bloody diarrhea history, you have to just consider Shigella. Okay, so at least in this one, like we said, Bacillus cereus, you would have a fried rice, egg fried rice history, consumption in a Chinese restaurant or something like that. A picture will be given. So you are right, and I think we have discussed traveler's diarrhea, but you have to make a note of all the causes, and I want you to exert a bit, all of you, and write down and list the causes. Like I will start here for you. Like Shigella, you have to note the word bloody diarrhea. Okay, so you have to write down something which will point you towards the correct diagnosis. Okay, so like that you have to write down for the other causes also. So please fill this table on your own so that you can revise correctly, and because we have already discussed it once, so there's no point going over it again. Let's do this one. Yes, Karthik. You are talking about hemolytic uremic syndrome, is it? I suppose, as a DD for enterohemorrhagic E. coli. You're right. E. coli O157H7 is exactly the cause for HUS. Okay, so all of you are right again. This is HHV8. So, while on the topic of Kaposi sarcoma, this is basically an sort of AIDS defining illness. Okay, so this is most common malignancy associated with HIV, and this is also associated with HHV8. Very correct. And clinically, it presents with PPP, that is purple pruritic plaque, and they can also metastasize to the lymph nodes. Okay, and how will you diagnose it? Only with biopsy. And how will you treat it? With, first of all, you have to reduce the immunosuppression that would be there in certain cases. If the patient is already on immunosuppressants, please consider reducing the immunosuppressants. See, the guidelines for diagnosis, they change with each question. Okay, so if the patient is already on a certain sort of immunosuppression, then please go ahead and reduce it. And then the most important treatment will be antiretroviral agents. So for most of the things that are associated with HIV, the treatment basically is starting HAART. And specifically, if you want to talk about Kaposi, then you can also have radiation and intralesional chemotherapies. You have topical retinoids, cryotherapy. Okay, so these are the options. But the first answer will always be starting antiretroviral agents. Okay. Okay, so the next one, please. Okay, so today we are talking a lot about animals, a lot of animals, dogs, cats, rats. So I want all of you to answer this one correctly, because all of you answered about cat scratch disease previously correctly. So coming from your answer, I could rule out these two, because all of you said this causes cat scratch disease. Okay, this one is the cause of ORF that you get from cattle. And Satyam says E, and Dr. Aisha says D. So I've already ruled out three options based on your answers today. So there's a conflict of interest over here, and most of you are saying E, but the answer is D. And why the answer is D is because this man was bitten by a rat while he was in China. China is not in USA, and Streptobacillus moniliformis is the most common form which is present in USA. Okay, and Spirillum minor is present in Asia. Okay, okay, good, Karthik, you're right. So let's talk a little bit over here about rat bite fever. I'm actually happy to see that most of you answered Spirillum minor, and some of you have answered Streptobacillus moniliformis. Actually, both of you are correct, but in this particular case, so when the patient is coming from Asia, then the answer will be Spirillum minor. This is the strain that is present there. And when the patient comes in from USA, the strain will be Streptobacillus moniliformis. So that's how you differentiate. Okay, this gives a relapsing remitting sort of a fever. And you have an indurated lesion at the bite site, indurated as well as ulcerated lesion. And you also have how do you treat it? As simple as that. Like I said, animal kingdom, you treat it with doxycycline. Okay, but in this case you can also treat it with penicillin. But if the patient is somehow allergic to penicillin, then you can go ahead with tetracyclines. Okay, and you can do a lymph node aspiration to diagnose it, as well as you can do serology via blood cultures. Okay, that's what it is. So ORF, that parapox virus you get from sheep and goat. All right, so moving on to the next one. Okay, uh, as crack medic family is expected, guys are answering absolutely very correctly. This is schistosomiasis. So this is what I was talking about when I was mentioning fresh water. This water doesn't look so fresh to me, but yes, freshwater swimming is what causes schistosomiasis. What you have to understand is, yes, Malik, Pavan, Tinu, Renu, all of you are right. Freshwater swimming in Africa region causes something called as schistosomia hematobium. Okay, so schistosoma hematobium, this is also notorious for causing squamous cell carcinoma of the urinary bladder. Now the question can try to trick you by mentioning transitional cell carcinoma, but that is not the case. It causes squamous cell carcinoma. Okay, while if the question mentioned about South America and Far East, the options will change. So for South America, you have Schistosoma mansoni, and for Far East, you have the name of a country, Schistosoma japonicum. Not very difficult to remember. Okay, so do you have something called as swimmer's itch? but here we are basically talking about Cystosoma hematobium, that is in Africa. So guys, be aware when you are on your trip to Africa, don't swim in freshwater lakes. You can have something called as swimmer's itch, and it develops quite quickly within 24 hours. Okay, we'll come to that. And this is also known as cercarial dermatitis. Okay, this is the acute form. The chronic form is known as the Katayama fever. Okay, it develops somewhere around 4 to 8 weeks into the disease, and you have dyspnea, cough, and an allergic marker for a trachea. Okay, so that's how this thing develops. How will you treat it? Treatment is with praziquantel. All right, moving on to the next one. Question number 23. A patient coming from Bangladesh, India, and Pakistan. TB is a very strong differential diagnosis. So remember that. Okay, Renu is quite quick to answer that. Tinu also says C. Karthik also says C. So let's go with C. You're right. Basically, meningeal tuberculosis, you have to give the treatment for 12 months. In pulmonary tuberculosis, like you all know, the treatment is totally for 6 months, right? In that 6 months, the initial 2 months, you have 4 drugs. That is, like one of my friends said, it's isoniazid, rifampicin, pyrazinamide, and ethambutol. Correct. So for the remaining 4 months, you have only isoniazid and rifampicin. Okay, but in cases of meningeal TB, the same treatment goes on for 12 months. Plus, most importantly, you add prednisolone. Alright, so please remember, prednisolone you add in a tuberculosis patient only when he or she has developed meningeal signs. Okay, moving on to the next one. It's quite an easy one, but can be confusing, and that is why I put it there. So let's go with what all of you are saying again, erythema marginatum, because erythema marginatum this is seen in somewhere else. That's not Lyme disease, that's rheumatic fever. Erythema marginatum is seen in rheumatic fever. Okay. So this is what our Lyme disease looks like, and this is the characteristic bullseye appearance, as you can see. Okay, so this is the erythema chronicum migrans, and this is the tick that bites and causes Lyme disease. Okay, and this is how your erythema marginatum that is seen in the trunks and proximal limbs of rheumatic fever patient. Don't worry, you're not getting any images. These are just for guiding you a bit. Let's talk about Lyme disease a bit. Caused by Borrelia. Burgdorferi. And then you have a tick which bites and causes Lyme disease. Usually the question stem will mention a tick bite site will be visible. Okay, a patient, when the patient goes on for hiking or tripping somewhere, traveling, then they can have this. And what they have along with this is erythema chronicum migrans. So when you migrate from somewhere, you get Lyme disease. Okay, so there are a lot of complications in this. Like in the heart, you can get a picture of heart block, second degree or something like that. You can have an increase in the PR interval. Okay, you can also have myocarditis picture. All right, in the CNS department, you have palsy, cranial nerve palsies. You can have Bell's palsy or a single other cranial nerve palsy. You can also have meningitic picture. So quite a lot of symptoms you will have, and the joints will have polyarthritis. And how will you diagnose? The diagnosis is via ELISA to antibodies that are produced to Borrelia. And treatment, again we have a tick, so the treatment will be doxycycline. Okay, that's how you can remember this. But then the treatment is quite prolonged. It's for more than a week. It's for approximately 2 to 3 weeks. While on the topic of Lyme disease, I would like to tell you about a small question, which is Jarisch-Herxheimer reaction. This will happen when you start the antibiotics. At the start of antibiotics, you give the patient the first dose. Okay, they will develop fever, rash, and tachycardia. So what do you have to do? You don't have to do anything. You just have to continue the treatment. This will go off on its own. This is also seen in syphilis. Okay. Okay. So that's how you go about Lyme disease. And yeah, let's move to the next question. Hmm. So all of you have started answering again. That is D. Okay, so you are right. This is progressive multifocal leukoencephalopathy. So all of you are right again. So whenever you see this word periventricular and subcortical demyelination, this is very characteristic of PML. Okay, just remember this. And raised intracranial pressure or absence of SOL, this basically helps you rule out other things. Okay, so these are ruled out. Okay, so just a small thing on this one, I want to tell you that while we are here on antibiotic reactions, in cases of infectious mononucleosis, the question stem will mention young adult, let's say 18 years or so. Okay, so when the first antibiotic dose is given, when you give amoxicillin particularly, they will have a widespread rash. Okay, so this is very characteristic of infectious mononucleosis. So this happens only with amoxicillin, so you don't have to prescribe amoxicillin in that case. Okay, moving on to the next one. So Pawan is quick to answer this one. Right answer is B. The question is being asked about least likely, and I think Tinu, you're confusing. Sorry, Tinu, you're right. Satyam, you are getting confused with most likely. So it's not the most, but it's the least likely. Okay. So these are all your encapsulated bacteria. This is a gram-negative one. So that's how you go about. Yeah. So in cases of splenectomy patients, the encapsulated bacteria, for example, your strep pneumonia, then you have H influenza, and then you have Neisseria meningitidis. These are your high risk infections. You also have certain gram negative bacteria like Pseudomonas, Klebsiella, and Salmonella. Okay, so another question that can come up will be vaccine or splenectomized patients. So in case you are planning a splenectomy, you have to give the vaccines 2 weeks before the planned surgery. Okay, but somehow if you are not able to give it, then at least after 14 days of procedure. Okay, so and what all vaccines you will give, few you should know and remember. First one will be pneumococcal vaccine in that order: the H influenza type B, Hib, and You have influenza vaccine also, seasonal, certain, and meningococcal C. Okay, so Karthik is saying that 4 to 6 weeks prior or 2 weeks after surgery. You're right, after 14 days or 2 weeks. But in cases of previousness, it's not necessary for 4 to 6 weeks. You can give up to 2 weeks before. Okay, I'll just change this word. So up to 2 weeks before of surgery, and definitely after 2 weeks of the procedure. Sorry. Okay. So the next one here. It actually becomes very exciting when all of you are so much interested and actively involved. And your active participation is the one which drives us also to work for you guys, of course. Okay, so we have a general consensus here. Albendazole, treatment for hydrated disease, albendazole is the right answer. And you have the causative organism called Echinococcus granulosus, causing hydrated disease. Basically, dogs are the definitive hosts. Humans are incidental host. Okay, and sheep, goat, etc. are their intermediate hosts. So life cycle goes on in these two, but incidental host. So these two basically life cycle goes on, and humans are the incidental hosts. Treatment is with albendazole. All of you are absolutely right. Let's move on to the next one. Okay, Malik is saying B. Would you like to revise your answer, Malik? Pawan is saying D. Okay, I'll sort of ease it up for you guys. Um, this 4 kg weight loss is the one, I guess, which is causing sort of confusion to you guys. This is a case of traveler's diarrhea, like we have discussed earlier. Yes, Kartika, you're right. This is a good case of giardiasis, and metronidazole is the right answer here. So in this case, you have to give metronidazole. Giardiasis in itself is totally harmless, but in certain cases, when the patient is immunosuppressed or immunocompromised, it actually increases the morbidity very heavily. So you have to address that in certain cases, but otherwise it's pretty much same. So the diagnosis is via cysts and the trophozoites in the stool samples. Okay, and most sensitive for this is ELISA, and the treatment is metronidazole, like I said, but the treatment in cases of a pregnant patient will be paramomycin. Okay, so we have reached the penultimate question of the evening. Okay, so all of you are very familiar with the guidelines. I cannot say no to your answers. All of you are absolutely right. These are the warts in the shaft. Okay, you can see the wart here. Okay, this is how it looks. So while on the topic of warts, that is condyloma acuminata. Okay, this is caused by HPV 611 serovar, and the treatment is a little bit different for different cases. So in cases of solitary keratinized wart, you can go with cryotherapy, because obviously you can understand you cannot apply cryotherapy at multiple places. So in cases of multiple non-keratinized warts, the treatment would be topical photophyllum. Also in cases of resistant warts, the treatment is imiquimod. Okay, I hope that solves a lot of your doubts. Yes, Malik, you're right. So coming to the last question of the evening. It's a very simple one. Okay, all of you are very quick to answer this one as well. So we are talking about NRTIs. Okay, so all of you have answered it correctly. Avan, it's okay to get confused sometimes, but yeah. So zidovudine is the right answer over here. Let's have a look at the table. So this is your antiretrovirals table that I have made for you guys. It's very important to go through this. Like I said before, this question can also come up as a part of your pharmacotherapeutics. So you have to just go through this table and remember, in cases of treatment, you basically give treatment with two NRTIs and you give one other agent from the NNRTI or the protease inhibitors. Okay, like when you start the treatment for HIV. Okay, so guys, it has been absolutely amazing. All of you have been answering absolutely crazily well and much beyond my expectations. So I can see that all of you are bang on track and your preparation is actually going well. So just keep up the pace and keep doing what you're doing, because I think you've answered more than 90% correctly, which is very good. So just keep up the pace, stay positive, most importantly, and stay happy and stay safe. See you next week for neurology class, I suppose. And till then, keep revising, keep working hard. Okay, see you again. Thank you. Good evening. And once we upload our video, there's one more thing that we are going to upload the respiratory and this video as well simultaneously. So don't forget to drop in your comments in the comment box once it opens up, because I guess it's not opened up right now. So once it opens up, please do drop in your comments and share it with your friends if you like it. And let me know also what other things you would like to see. Okay, so see you next week. Take care. Please be fine.